Hello, I'm Dr. Rita Sakr, consultant breast oncoplastic surgeon and gynecologist, director of breast clinic at Emirates Hospital Jumeirah. Today we have with us Dr. Louise Andre. She's a breast interventional radiologist in our team, and she had joined us recently. Dr. Louise, please can you introduce yourself to us?
Thank you, Dr. Rita. I'm Dr. Louise Andre. I train in Paris for radiology, and then I specialize in breast imaging and women imaging. Then I moved to London, where I worked on AI project at King's College, and then I worked at Guy's Hospital in the breast unit, where I used to be part of the breast team, doing all the type of imaging and biopsy. And then I moved to Dubai.
Welcome, Dr. Louise. We're very happy to have you in our team and looking forward to more and more from these progresses in breast care and the breast radiology and the general breast care. So we know that awareness is not only about October and Pink October. Awareness is an everyday awareness, every month's awareness. So in addition to all what we have learned about the self-examination, about doing the regular checkups, we know that breast radiology plays a major role in the screening and in the awareness. So Dr. Louise, can you tell us about the role of imaging in the screening, in the awareness, and what are the modalities that we need to follow?
The aim of screening is to detect a disease before any symptoms arise. Because if we detect the disease early, it's going to be, we're going to have a better treatment and a better outcome. So in breast imaging, we've got several modalities for screening. The key examination for screening in breast radiology is mammogram. So mammogram is an X-ray of your breast. And on a mammogram, we will look for many things. So we will look for mass, we will look for calcification, and we will look for a change in the architecture or asymmetry. We have standard mammography, 2D mammography, and also 3D mammography. And on the 3D mammography, we can see the breast on different layers, and it enables us to see better within dense breasts. We also have ultrasound. Ultrasound is used in screening for women with dense breasts. And it is used in screening if we see something on mammography and we need to look a bit closer to it. We also have MRI, but MRI is reserved to patients with high risk. So you need to evaluate your risk with your doctor, and then we can propose, if you are a high-risk patient, we can propose you to have MRI also in your screening. There are also emerging techniques like contrast-enhanced mammography. They are not in routine for now, but they are a good hope because they can be very helpful in the future with dense breasts. But
thank you so much for this really overview of all the modalities. Now we know that the screening should start at the age of 40, right, with the mammogram. And one of the myths that we all hear everywhere about the safety of mammogram, and we try, all of us, to rectify the wrong concepts. Is mammogram safe, Dr. Louise?
This is a question I have a lot with my patients, and I want to tell them, yes, mammography is safe. The radiation dose is approximately 0.4 millisieverts. It's the equivalent of 7 weeks of natural radiation exposition and approximately 40 hours of international flight. So it's 2 round trip between London and New York, for example. Theoretical risk of radio-induced cancer is very, very low, and it is the benefit to do screening mammography is much more important. And since the 90s, in the US, we think that the studies are showing that between 380,000 lives and 600,000 lives have been saved with mammography and, of course, with improved treatment as well. So yes, mammography is efficient and safe examination.
Yes, so mammography is safe. Please don't forget to start your mammogram at the age of 40. Now, if we are doing all those images and the screening, can we tell only from imaging if a lesion or a mass or a nodule is benign or malignant?
So imaging gives us very good insight in what we can see, but sometimes it's not sufficient. So as breast radiologists, we use BI-RADS system. So we look at your breast, we look at what we find, and we can classify all the lesions that we see and all the things that don't look as normal breasts. So we have a list, like, for example, cysts. Cyst is a small sac with fluid within, and on ultrasound, it appears like a small ball with fluid content, so it's totally black on ultrasound, and behind we can see that there is posterior enhancement because ultrasound goes straight into the fluid. They are not attenuated by fluid, whereas they are attenuated by the tissue around. So actually it's very typical, and we are sure that there are cysts and they are benign. On mammography as well, there are calcifications that are typically benign, like popcorn calcification or vascular calcification. And in the BI-RADS system, all of these abnormalities are classified as 2. These are benign and, okay, it's part of your breast. Then for other things, we have benign criteria. For example, on ultrasound, if we see a mass, we want it to be smooth, so well-defined, oval, parallel to the skin with no posterior attenuation. If we have all the benign criteria, we need another one. We need the stability within time. Mm-hmm. So we will ask you to come back and we will follow you 6 months later, 1 year later, 2 years later, because we want 2 years of stability to tell you, okay, this is sure, this is benign. This is what we call BI-RADS 3. If we miss one benign criteria, it won't be BI-RADS 3, it will be BI-RADS 4. Mm-hmm. And then we need to take a sample, send it to the lab, because only the lab will be able to give us an answer. And we don't want to wait for a stability criteria, whereas because we don't have the other benign criteria. So we need to check. We need to send a sample to the lab and check what it is.
So this is the biopsy?
Yes, biopsy.
So what are the modalities of the biopsy that you can perform?
So we can perform biopsy under mammogram if it's something that we can see only under mammogram, or under ultrasound if we can see under ultrasound, because it's easier with ultrasound, it's more comfortable for the patient. So we receive you, we clean the skin, we've got sterile material, we are in sterile condition, and then with ultrasound we will see the lesion. We will do local anesthesia, so you don't feel pain, okay? You just feel a bit of pressure, and that's totally acceptable. And then we put a needle inside your breast, and under ultrasound guidance, or under mammography, when it's mammography, we control the needle at all times, so we are sure where the needle is. It's not close to the chest wall, it's not close to the skin, and it's going right to the target. And we are sure to biopsy what we want to biopsy.
And this is where you have the diagnosis and the confirmation of
we take
benign
a sample,
or malignant.
We take a sample, we send it to the lab, and the lab tells us what is this lesion.
So another myth again, is biopsy safe? We hear it a lot, that biopsy is spreading the cancer. So, and we know this is wrong because it is necessary, it is a tool for diagnosis. So is biopsy safe?
Yes, biopsy is safe. If there is a cancer, we need to know that there is a cancer before doing cancer treatment. So we need to do the biopsy. Biopsy is safe. We are just going through the skin towards the lesion. Main complications are very rare, less than 1%. Main complication will be bleeding, bruising, because
But it will disappear. Those
bruising,
are minor complications.
This is minor complication. Bruising will stay for a few days, between 10 to 15 days, and it will disappear.
But the benefits are crucial because it gives the diagnosis, right?
Yes, benefits are crucial.
And another question about when we do biopsy, you are leaving a clip, right? Because we need to know where the lesion is, correct?
Yes.
So is the clip safe? We have a lot this question, people traveling, going around. Is the clip after biopsy is safe?
Yes, the clip after biopsy is safe. This is a small metallic part of titanium, biocompatible titanium. It will stay in your breast. It's very important because we biopsy something and we want to make sure that we mark the area of what we biopsied. Because sometimes when we biopsy, for example, calcification are very tiny, and sometimes we biopsy something like 3 millimeter, very early stage of cancer. And when we biopsy, we take all the calcification. So after, if we remove the needle, we don't know exactly where it was. So we leave a clip and we are sure about where it was, because if something comes back as a cancer, we need to go back to remove more tissue with surgery at some point. So we need to know where it is. And even for benign lesion, it's important because sometimes I have patients coming to me. They were followed somewhere else, for example, in another country. They come to me and say, yes, I had a biopsy once. It was a few years ago and it was in the left breast, but I don't really know what it was. It was benign, and when I do my examination, sometimes I find something that doesn't have all the benign criteria, but there is a clip inside and I know it was biopsied, it was benign. So I will follow it up again, but I won't go straight to biopsy. I will just follow it up, and if everything is fine,
so the clip is important and it is safe.
Yes, it is safe. It won't be at the airport. You won't feel it. It's smaller than a rice grain. It can stay there for years, no problem.
Thank you, Dr. Louise. Now, we know more and more with our interrogation and with our questionnaires, discovering family history, people with parents or cousins or mothers with breast cancer. So how family history of breast cancer affect in your modalities of follow-up from the breast radiology point of view?
So we will always ask about family history because you can be at higher risk of breast cancer if there are many cases in your family of breast cancer. So we will ask for breast cancer, ovarian cancer. We will ask what age did this cancer appear in your family. It won't be the same if someone in your family had a cancer at 30-year-old or at 80-year-old. It's not the same risk. It enables us to evaluate your risk. And if there are many cancer in your family, cancer in young age, ovarian cancer, or breast cancer in a male in your family, we will refer you to genetic counseling. And with genetic counseling, we can adapt our screening. We can propose other modalities. For example, MRI. MRI will come to screening for you. We will combine this with mammography and ultrasound at some point, and then 6 months later MRI, and then every 6 months we will follow you with either MRI, either mammography and ultrasound. And this is very important because when you have genetic predisposition to breast cancer, sometimes it can happen in a very young age, and it can go very faster. So we want to have a close follow-up for you.
Anticipate, to have like a proper and detected very early, because again, early detection can save lives, and it's very, very important to follow the agenda and the calendar of test and screening suggested by your doctors. Now, we know that there are benign lesions. Do we always have to go to surgery for those benign lesions? So what are the criteria where maybe breast radiologists can help, and how can you help with benign lesions?
So some of the benign lesions don't need to be removed at all. Sometimes you have a cyst and it doesn't bother you. You have a fibroadenoma, which is totally benign and it's not very big. So we can just leave them and just do a follow-up. There is nothing to remove. Sometimes we find benign lesions that need to be removed because maybe they can create symptoms, or they can be sometimes associated with predisposition to cancer. So we need to remove this lesion. For example, papilloma. Papilloma is something that develops within your ducts, and it can makes you have nipple discharge. So we remove these lesions. If these
How can you remove it from the radiology point of view?
If these lesions are less than 1 centimeter, we can propose you a vacuum-assisted biopsy. So we put a needle that is a bit bigger than the classic biopsy needle. It uses aspiration, and we can aspirate under ultrasound control the whole of the benign lesion.
Mm-hmm. Interesting. So how many kinds of benign lesion we can proceed this way, and we do not have to do like a breast surgery for it? There are guidelines, like you have recommendation for a certain type of benign lesions?
We can remove benign lesions up to 1 centimeter.
Okay. Any papilloma or
papilloma or radial scar as well, up to 1 centimeter. We can remove.
Perfect. This is really in advance and helping to avoid maybe unnecessary scars for the patient.
But if there is cancer, surgery is needed.
Definitely. Now we know that it is very important more and more to highlight the multidisciplinary approach of any diagnosis, mainly when it is a cancer diagnosis. So how the breast radiology contribute in the multidisciplinary approach and care of the patient?
So as a breast imager, I'm always in touch with the surgeon, with oncologists, with radiotherapists, with pathologists. So I will do the imaging. Then if there is something suspicious, I will go to biopsy. I will do the biopsy under ultrasound guidance. And then when the results comes back as cancer, we will do more imaging to assess the whole breast, so the other breast if needed. So we can add MRI, and we can, of course, we will do the full screening of the body to make sure that the cancer is still localized. We will assess the axilla again to make sure that there is no suspicious node, because it will change the treatment approach. And then we will do a multidisciplinary meeting with all your physicians, so from oncologist, pathologist, surgeon, to assess what is the stage of your cancer and what is the best approach to treat it.
A plan of treatment. Now, when breast surgery is required, how in any way the breast radiology is helping the breast surgeon in the plan of surgery and in the performance of surgery?
Yeah, so in the plan of surgery, we will assess the whole area. So we will tell the surgeon if the cancer is only in one side of the breast, in several sides of the breast, what is the distance between the two tumors, if there are two tumors, what is the distance between the tumor and the skin, between the tumor and the nipple, between the tumor and the chest wall, and all of this will affect the surgery. We will also assess the nodes, because if there are suspicious nodes, the surgeon will need to go to the nodes. And if there are nodes as well that are not in the classical axillary regions, because the axillary region is divided in 3 levels, and classically the surgeon is going to the first one. If there are nodes in the second or third one, we really need to give them this information. In preparing the surgery, we help the surgeon with our clips, because we clipped the lesion, and when the surgery is coming, we will put another clip a bit different for localization, or
a wire.
A wire, thank you, so that the surgeon knows where to go. And sometimes we can also do that, like bracketing, putting one clip at one part of the tumor, or if there are 2 tumors, and another clip at the end of the disease. So he knows exactly what he needs to remove.
And this is a very, very major support and contribution, because when the lesion is not palpable, we cannot feel it. We need to know where we are going. So it's very important, the localization of the tumor and the lymph nodes when we need to remove a positive lymph nodes. Thank you so much, Louise. Now, how can you help the breast oncologist with their evaluation and with his plan of treatment?
So first, for the oncologist, we will give him the stage of the cancer, if it's localized or if it's spread, because it will change if he will go directly to chemotherapy or not. And then we will follow, when we start chemotherapy for a patient, we will follow the patient with our imaging. We will monitor the tumor. We will see if it's decreasing in size, to make sure that your treatment is the best treatment for you. If it doesn't decrease in size enough, the oncologist may change the treatment and adapt the treatment so that you get the best treatments.
Very good point. So again, it's a multidisciplinary approach where all parts, all specialties contributing together in the plan of care and the treatment. Now, when we are done with the breast cancer treatment, what is the role of the breast radiologist in the follow-up of a patient breast cancer survivor? And what are the modalities again?
So when a patient has finished her treatment, we will follow her for a long time. So first, after 6 months, we will do a package imaging with mammogram and ultrasound. And then every year again, we will follow up the patient with mammogram, both sides, and ultrasound. With ultrasound, we will look, and mammogram, we will look for sign of recurrence, or if there is not new cancer as well. Sometimes we can add MRI for high-risk patients, or for patients who had very dense breasts and for who the first tumor was not very well seen on mammography or ultrasound at the first time. So we can also add MRI if needed.
And also for mastectomy. So this goes also for mastectomy, the need for a follow-up.
Yeah, we need follow-up because sometimes it can come back.
Yeah, so we need to complete with ultrasounds and maybe also mammograms, even if we do mastectomy, especially with the skin-sparing mastectomy. Sometimes we have residual tissue, so we need to make sure we are doing our imaging, our radiology imaging with the breast radiologist follow-up. So now moving to a new era, we hear a lot about the AI. The AI contributing in many fields, including in breast radiology. So what is your input about that, and what can you tell us about it?
Yeah, I think AI will change our practice in the best way for the patients, because AI is like a teammate. It can detect really, really little things that sometimes are not seen by radiologists. And AI is never tired, and it can help us looking at some very specific area. AI is trained with thousands and thousands of mammograms, and AI, the majority of mammograms are normal mammograms. AI is very good at seeing what is normal as well. So it's very reassuring for us to confront our reading to an AI that say, okay, that's normal. And we can go quicker to the mammogram that needs our eye, needs our expertise. Because it will say, okay, in this area you need to check. It's very sensitive. And our eye can say, okay, this is normal or not, or we need to do biopsy. So I think AI will help us be more efficient. And what I heard yesterday as well in a webinar by a professor at Cambridge University is that AI is very good at predicting your personal risk. Mm-hmm. So in the future, your mammogram will be seen by AI, and this AI will give you a risk of cancer at 2 to 5 years. And we will adapt your screening with this. This will be, because for now we assess the risk with scores, and these scores are not perfect, and AI is doing much better in assessing your risk. So with this assessment, we will be able to tailor your screening.
Very interesting, and definitely in many fields it will be very contributing to help in screening as much as in diagnosis and prediction. Now, talking about the conference, so how a breast radiologist is keeping up with all, we have a lot of conferences and updates and guidelines. How do you keep up with all those updates so we can provide the best care to the patients?
Yeah, so it is our job as well to be up to date, of course. And so for me, I try to review sometimes reference journal like radiology, and AI will help us as well, because AI will be able to give us all the new articles that we are very interesting for us. We don't have to look for specific things. AI will be able to give us what articles we need to review. I'm a member as well of European Society of Radiology, French Society of Radiology, European Society of Breast Imaging, and all these societies propose webinars, online courses, and of course conferences. So each year I try to go to the General Congress of Radiology, either European Society of Radiology, either French Radiology Society. And of course, to keep our license as well, we need to have CME credits. So CME is for Continual Medical Education. We need credits. And all these conferences, these lessons can give us points, and we are regulated, and we need to update our knowledge so that you can get the best care, of course.
Good. 100%, because all of this information, with all the research, with all the advances, we have definitely more and more information, and this is the way to get those information and put them for the benefit of the patient care. Thank you so much, Dr. Louise. Now, what are your messages to our dear patients?
So to our patients, I would like to tell them that we are here for you at all the steps, from screening to treatment to follow-up. You are not alone. We are here with you. I would like to remind them that self-checking is very, very important. Please do that. It's very easy, very quick, and do your screening every year, because 70% of the breast cancer occurs in families with no family history of breast cancer. So everybody is involved in this screening. So you please do your screening, because it saves lives every day.
Agree. So definitely self-examination every month after the period, mammogram at the age of 40, sharing family history with our doctors. So please, because early detection can definitely save lives. Thank you so much, Dr. Louise.
Thank you, Dr. Rita.
Thank you. Thank you so much for listening, and please stay tuned for another episode from Al Majlis podcast by Emirates Hospital Groups.